Not letting me. Here's I can tell it's not letting me share desktop. Okay, I guess it's about time to begin. Um, if actually I can't do that unless I increase my volume. Let me finish sharing. Get my volume up here. All right, I see there's just me and George. George, can you hear me? And what do you see right now?
I just see you. Can you hear me?
Yes.
Yeah, I just see you.
So I'm going to, in theory, share screen, and I hope you will see the whole of the PowerPoint presentation. Let me know if you don't, okay?
Yep. I see the PowerPoint.
Okay, good. I guess we're ready to go then. Somehow my little icon on the, little control panel disappeared. I never trust these systems. All right, so what I'm going to talk about tonight is the normal the electrocardiogram. And at first we'll look at the normal electrocardiogram, and then we'll look at how we can use the electrocardiogram to, in fact, detect various abnormalities within the heart. Um, so I'm going to start with a little historical introduction. And this is a very early tracing of what purports to be an electrocardiogram. Was presented, as you can see, in the Journal of Physiology in 1887. And you can see these recordings, this recording here, where you see this tracing. And one presumes, uh, one can't be sure because I actually haven't seen the paper, but this probably is the equivalent of the QRS complex. And then we see this um, depression here, which may be a T wave. Um, but this was a very early attempt to do it. And it isn't until um, people devised a little more elaborate machinery, as you see here. This is a turn of the century, turn of the 19th to 20th century uh, electrocardiogram machine. And you can see that it's got all this fancy electrical material here and dials and switches and all the rest of it. And the subject, you'll notice, is sitting with his limbs, at least three of his limbs, in buckets of saline. Um, and this is still the kind of configuration, although we don't stick our limbs in buckets of saline anymore, but there's still the kind of configuration that one is going to see in terms of EKG, where you have electrodes on the right arm, and left leg, and the right leg serves as a ground. And you can see the little couple wires here anyway coming from some of these containers. And this is Einthoven's definitive EKG. I say definitive EKG because he actually had a form of EKG that he did earlier, which showed a different wave pattern. But this one shows the classic PQRST waves that we know, along with the time frame here. And this was published, as you can see, in Fleury's Archive in 1895. And Wilhelm Einthoven was sort of, if you will, the father of electrocardiography. What he was actually recording, it's a galvanometric recording where you are recording electrical activity on the surface of the skin as a result of electrical activity which occurs in the heart. And that's the whole, if you will, the very simplified explanation as to what an EKG is all about. Now, let me go back to this last, I want to go back actually to this tracing. This tracing was probably done on a kymograph. And a kymograph looks like this. And certainly in the days that he used it, it was going to look something like this. And in fact, you can see that this is a mechanical kymograph as opposed to the kymograph over here, which is driven by electrical activity. But the way in which the kymograph works is that the drum rotates at a constant speed, and you can have, and sophisticated ones, you'll have ones that will indicate the time frame, like it'll make a tick every second or half a second or whatever. But if you look carefully at the tracing over here on the right, you'll see that you have a stylus which seems to be etching something onto a black drum. And that blackness that you see there is a piece of smoked paper. And that was the way in which you recorded it. Now, this meant that there were several interesting little things one had to do to perform this kind of operation. One of them, of course, was to produce the smoked paper in the first place, which meant that you went and took this paper and held it over a burning tub of hydrocarbons. It was really very disgusting kind of thing. And then you'd put it on there very carefully, line it up, get it running. And when you were done with your tracing, what ended up happening was that you would, if you wanted to preserve the tracing, you'd have to run it through a tray of shellac. And the shellac would give you a coating on that piece of smoked paper so it wouldn't erase off if you touched it. So here is a normal EKG. I actually showed you this, probably at least one of these in the last slide, last lecture. But I'm going to sit on this for a little bit of time and remind you about the electrical conductance system within the heart. So it is the sinoatrial node where the impulse is going to start. And the sinoatrial node is responsible for generating in a normal heart the impulse in the heart. And therefore we call it the pacemaker. And we know that it's found in the right atrium of the heart. It will have an autorhythmicity in the order of 60 to 100 beats per minute in a normal heart. Now, since the heart is divided into the two atria and the two ventricles, there needs to be a connection between the chambers to make sure that the electrical impulse, which is generated in the pacemaker, can travel throughout the other chambers. And in order to accomplish this in the atria, there are a series of pathways that are called the internodal pathways. And these form effectively a passage, a link between the SA node and the AV node. And there are three of them canonically in the right atrium. And then there's another pathway, Bachman's bundle, which conveys the signal to the left atrium. In the center of the heart, in the vicinity of the annulus fibrosus, between the atria and the ventricles, is the atrioventricular node. It helps slow down the conduction rate before it reaches the ventricle. And this delay is essential because this will ensure a proper movement of the blood and proper volume of the blood. Now, due to this delay function, effectively what it means is the atria can contract, squeeze that last 20% or so of blood into the ventricle. And then the ventricles can contract. Once you leave the atrioventricular node, you enter something which is either called the atrioventricular bundle, or generally it's eponymically known as the bundle of His. And these are specialized cardiac muscle fibers. In fact, all the pathways in the heart specialized cardiac muscle fibers. And they're located in the inferior part of the interatrial septum. And they transmit the electrical impulse in the AV node to two divisions, which are called the right and left bundle branches. The left bundle branch conducts the impulses toward the left side of the heart, the left ventricle. And these fibers will lead impulses into the left ventricle and initiate the contraction within the left ventricle. And the right bundle branch basically does the same thing as the left bundle branch, carrying the impulse into the cardiac myocytes of the right ventricle. And then terminally within this system is what we call the Purkinje system. Now, these are, again, cardiac muscle fibers, which have been highly specialized to conduct the signal very rapidly. Now, how do we apply this then to the EKG tracing that we're going to see? So here is a view of a standardized EKG with lots of information on it, tell you various things. Now you'll notice the EKG tracing is a combination of various waves, intervals, and segments that denote the condition of the heart. First, the P wave, right here. This is the first wave in an EKG tracing, and it's certainly in the three limb leads, a positive wave. So in other words, you find it in this upright position like this. The P wave denotes the depolarization and contraction of the atria. This wave therefore represents the journey of an electrical impulse generated by the SA node towards the moment when it reaches the right atrium, it spans towards the left atrium via Bachman's bundle. This impulse in P wave is ultimately what's going to cause all of the myocardium to contract. From the P wave to the first of this complex here, we call the QRS complex, we have an interval which is called the PR interval. And they show it over here on the right-hand side. Some people call it the PQ interval because you actually don't measure to R, you measure to the start of Q, but it's kind of canonically called the PR interval. And it's a representation of the delay that's occurring in the AV node. And again, this is a very important part of the EKG tracing. The lack of a PR interval could indicate that both the atria and the ventricles are contracting simultaneously. The simultaneous contraction would obviously hamper smooth blood flow and could lead to numerous cardiac conditions, complications. This interval is a measure of the lag between the P wave and the QRS complex. The QRS complex, QRS here, actually has it, well, you won't always see it so clearly, but has three clear deflections that follow after the P wave. And these are an indication of ventricular depolarization and ventricular contraction. The Q wave is the first negative in this lead here. It's the first negative deflection on the tracing. And it's then followed by an R wave, which is a positive deflection. So here's our negative Q, our positive R. And finally by an S wave, which again has a negative deflection. This part of the wave shows the journey of the impulse through the ventricular myocardium through the right and left bundle branches. It also indicates the rapid action of the Purkinje fibers, which is responsible for the quick travel of electrical impulse to the terminal fibers. We then have an area at the end of the S wave before the beginning of the T wave that we call the ST segment. And this measures the distance between the end of the S wave, actually it measures the time between the end of the S wave and the start of the T wave. The T wave, which is the wave which follows the QRS, here's the T wave, is a small, rounded, generally upright wave. And this is an indication of ventricular repolarization. Once the ventricles have fully repolarized, then they're ready for the next cardiac cycle. Occasionally, you will see a small wave, very small wave, following the T wave. This is called the U wave. It's not shown in this diagram. This is an indication of the repolarization of the Purkinje fibers, and again indicates that one cycle of the cardiac system is completed. And again, this is probably more visible in a heart with slow heart rate than one with a faster heart rate. The rate, beats per minute by the scale up here, indicates the number of beats produced per minute. It's mainly a measure, we generally measure it by the ventricular rate. Now, there are times when the atria and the ventricles may be contracting at different rates. And so therefore, you need to measure both rates. The normal range, again, lies between 60 and 100 beats per minute. In the case of a slow heart rate, bradycardia, the number of beats per minute is less than 60 beats per minute. While in the case of faster heart rates, over 100 beats per minute, we call that tachycardia. Now, in terms of figuring out the rate of the heart, you'll notice that the paper, the scale that the EKG is drawn on, has these big boxes, which are 5 by 5 little squares. And each big box on the time axis represents 0.2 seconds or 200 milliseconds. So it takes 5 big boxes to equal the duration of time of 1 second. On this scale, you'll notice that we've got 10 of those big boxes, so we're actually measuring 2 seconds of duration. Each of the small boxes then represents 1/5 of 200 milliseconds, which would be 40 milliseconds. Now, there's a very easy way to estimate the heart rate, and that is to, first off, it's easiest usually to see the RR interval. So we go from one R wave to the next R wave and measure that. And in this case, what we're going to do to determine heart rate is we're going to count the number of big boxes. So I've got 1 big box, 2, 3, 4, 5, and then 1/5 of the next one. All right. Now, notice that little scale at the top, a little sort of marker at the top, which goes 300, 150, 100, 75, 60. This heart rate is less than 60 beats per minute. How do I know that? Because if I count out in this RR interval the number of large boxes, I go, all right, 300, 150, 100, 75, 60. All right, now the next one, 6, let's see, 6 out would be 5, 6 out. This would be a rate of, down here would be a rate of 50. So this is about a heart rate in the vicinity of 58 beats per minute, which puts it into the bradycardic range. So again, simple way to determine the heart rate is to simply count the number of big boxes in the fraction, if you will. So again, 300, 150, 100, 75, 60. And then I've got that extra little fragment over there. My next box would be 50, so this would be 52, 54, 56, 58. If I now count from the right. So my heart rate is 58 beats per minute. The other thing to notice in this scale is the vertical scale, which is the measurement in millivolts of the electrical activity. And again, standardly, 2 of these big boxes equals 1 millivolt, either positive 1 millivolt or negative 1 millivolt. And that means that each of the little boxes is 1/10 of a millivolt in terms of amplitude. And sometimes you want to know what the amplitude is, and I'll actually give you an example of that a little later on. Also, generally in a EKG tracing, you'll probably have a little blip which will indicate what 1 millivolt is. In other words, a sort of timer signal there. The other thing to pay attention to in the EKG is regularity. Regularity measures the RR intervals and the PP intervals. If both of these intervals are consistent, it shows that the tracing is regular. If there's a repeating pattern, it indicates that it is irregularly regular. However, if there's no specific pattern, whatever, it means the tracing is irregular. So we have these 3 terms that we can apply to it. And that is regular, this is a regular tracing. Irregularly regular, because we have some repeating pattern of PP and RR intervals. Or irregular if there is no repeating pattern to them. Another thing which is occasionally going to happen in the EKG tracing is you may see a dropped beat. Now, what this means, when the dropped beat occurs, that means that you have failed to generate a signal in some way or other. If you don't have a P wave where you would expect there to be a P wave, then that means that this was not generated by the SA node. On the other hand, you might have a P wave and you would have no QRS complex that follows it. And that would mean that you have some sort of an atrioventricular block in place. So this kind of summarizes these slides. I'll just go through them reasonably quickly because it's sort of everything I've just talked about. P wave should precede a QRS. So in a normal EKG, every P should be followed by a QRS. Every QRS should be followed by a T. And every QRS should be preceded by a P. And again, now the PR intervals or PQ interval, if you will, this has a set value. If we go back here and you measure this, so this is our PR interval here. So now I'm just going to use, well, I can use the little boxes. So this is 40, 80, 120, 160 milliseconds, which if you notice here is the normal value. 0.16 seconds is 160 milliseconds. So 160 milliseconds is, and that tracing is normal. The QT interval, notice, has normal value of 350 milliseconds. So let's go back and see if that's true in this. So our QT interval, you'll notice, is from the beginning of the Q wave to the end of the T wave. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9 little boxes. And we know each little box is 40 milliseconds. So therefore 9 times 40 is 360. So it's certainly very close to this canonical 350 milliseconds. And besides determining the heart rate by using the paper, you can do it in another way, which is to count out the time interval. So notice that our time interval here from R to R goes from 0.4 to 1.4, what would that be, to 1.44. And so the difference is 1.04. And so therefore you would divide 1 by 1.04. No, 60 by 1.04. And that would give you the rate of 158 that we determined. So the reciprocal is to divide the 60 seconds by the time frame for one cycle. And this shows you the idea of depolarization, repolarization ways. And you'll note probably the most significant thing to notice in this, because obviously if the current is moving in the direction of the electrode, it's going to be an upswing, whereas if it's moving away from it, it's going to be a downswing. But the thing to notice is that when the ventricular muscle is either completely depolarized, which we have here, or completely repolarized, which we have here, the recording is a straight line. It's baseline recording. We call that the isoelectric line. And here's how to calculate the heart rate using the reciprocal function. So we have an RR interval in this case of 0.83 seconds, 830 milliseconds. We take the heart rate to be equal to 60 seconds per minute divided by 83 seconds per beat. So seconds will cancel and beat comes up top because notice it's in the denominator here. And so that gives us 72 beats per minute. In order to record the EKG, we need to have certain leads attached to the body. So we place these electrode pads and we connect cables to the box. And we call these particular relationships limb leads. So first we have what we call the bipolar limb leads, which are leads 1, 2, and 3. Now notice that right leg is ground, okay? And what we have here is a electrode on the right arm, an electrode on the left arm. And notice this runs directly across the heart. And we're running from negative terminal to positive terminal. Negative terminal on the right arm, positive terminal on the left arm. That's lead 1. Lead 2, on the other hand, we switch this positive lead here from left arm to left leg. And now this axis is going to go from right arm to left leg. And if you think about the position of the heart, this is certainly going to include much of the ventricles. And then for lead 3, we switch the negative from the right arm to the left arm, keeping the positive still on the left leg. And that gives us lead 3. Now, here is sort of what they look like in these tracings here. So the lead which generally has the highest amplitude is going to be lead 2, because it's running along the long axis of the heart, or at least most of the time. So again, to put into text what I just said, lead 1, negative on the right arm, positive on the left arm. Lead 2, negative terminal, right arm, positive terminal, left leg. Lead 3, negative terminal on left arm, positive terminal on left leg. Now, there is an interesting relationship called Einthoven's law, which says that the electrical potential of any two leads, any two limb leads, equals the sum of the other two. And make sure that you obey the signs. So one way of expressing that is 1 plus 3 equals 2. If you go back here and you look at these tracings, notice that lead 1 has a very strong positive component to it, but no negative component. Lead 3 has a slightly stronger positive component, but a large negative component as well. And if we add those two together, we got this lead 2. In other words, as I said, 1 plus 3 equals 2. And to put some numbers on it, if lead 1 has 1 millivolt, which would be a vertical 2 big boxes, lead 3 has a positive 0.5 millivolts, 1 big box, then lead 2 is going to be 1.5 millivolts. And again, to just sort of demonstrate that, 1 plus 3 equals 2. Another very important set of leads to put on the body are the precordial leads, or chest leads. And these are designated V1 through V6. And you see what the tracings look like for these. And first, we'll place them. V1, the electrode for V1 is attached to the pad here, which is located just to the right of the sternum in the 4th intercostal space. And V2 is on the other side of the sternum, the left side of the sternum, again in the fourth intercostal space. V4 is in the mid-clavicular line, this imaginary vertical line from the middle of the clavicle down, which effectively puts it in the fifth intercostal space. And then V3 is in between V2 and V4. V6 is in what's called the mid-axillary line. In other words, you're in the middle of the armpit, and you drop this vertical line, which again is going to be placed in the fifth intercostal space. And V5 is in between V4 and V6. Now, by the way, how do you know the fourth intercostal space? And the answer to that is, remember, you cannot palpate rib 1, but you do know that the sternal angle, where the sternal angle is, which is the junction between the manubrium, the body of the sternum, is located here, and that is where the second costal cartilage attaches. So that's your second rib, and the space below the second rib is the second intercostal space, third intercostal space, fourth intercostal space. And now when you look at this in terms of the vectors that are going to take place, you see in relation to this view of the heart here, you can see how the current is going to be measured. And remember that diagram about positive deflections, negative deflections. So you can again see that, notice V4 and V5 should have very strong components, positive components, as also to some extent should V6, because V4, 5, and 6 are in fact mostly concerned with left ventricle, and it's got a much larger mass, so therefore should have a much greater amount of current in it. So up here we see the standard placement of them, and now a couple of variations that come in. One of them is to put some posterior leads in place. Let me move this out of the way. Here is V6, remember, which is the mid-axillary line. We can then go over and place in the, let's see, second, third, fourth, fifth, sixth, seventh, looks like seventh intercostal space. Seventh intercostal space. We place V8, and V7 is in between those two in what's called the posterior axillary line. And then we have in intercostal space, eighth intercostal space, we have V9. You seldom see these, but sometimes it's necessary to do them. And another thing which sometimes happens is you discover that the individual's heart is not in the usual dextrosinistral angulation. Maybe it's in fact pointed, sinistral anterior, inferior, to the left and down. Instead, it's somewhat angled to the right. And so you effectively do that, just reverse your placement of your V leads if the heart is in fact oriented to the right, which it sometimes is in a right pointing heart. And of course, in a case of complete situs inversus, then it would be as well. So V1 is placed on the left side and is called V1R, V2R, V3R, et cetera, et cetera. Again, these are extremely rare. Almost never see them. Another type of lead we have is the so-called augmented unipolar limb lead. And notice what's going on in this particular case. Now what we're doing is we're combining the leads in our first case for left arm, left leg, And those are going to be then, our other limb lead is going to be placed over here on the right arm. This is called augmented vector right, or AVR. And you notice the direction of the current here. So the positive terminal is on the right arm. If we move the positive terminal to the left arm and now connect up right arm and left leg, we have what we call AVL. And if we switch it so that our positive terminal is in the left leg and hook up as negative portion, right arm, left arm, we have what we call AVF. So AVR, positive electrode, right arm, negative electrode on the left arm, but it's, notice, also receiving from the foot as well. AVL and AVF. And augmented vector foot is AVF. Now, to do a 12-lead EKG using the 3 limb leads, 1, 2, and 3, the 3 augmented leads, AVR, AVL, and AVF, you use a harness which looks something like this. And this connects via this cable to the machine, which is actually going to record and analyze the EKG. And these are the harness cables, which then get connected to the various electrodes that you have on your body. There's something interesting to note here as just sort of an aside. You'll notice that the ground, the right leg, is indicated with a black wire. I'm not quite sure why that happened in this circumstance, because certainly in electricity, dealing with electrical circuits, like the wiring in your house, green is ground the world around. But anyway, so again, here is a normal 12 lead. The only thing that this 12 lead is not showing you is a scout tracing. And that's important, as I'll explain in a minute. So we have lead 1, lead 2, lead 3. These 3 limb leads are all recorded simultaneously. AVR, AVL, AVF are recorded simultaneously, but subsequent to the recording of 1, 2, 3. V1, V2, V3 recorded simultaneously, but subsequent to AVR, AVL, AVF. And then V4, V5, V6 subsequent to V1, 2, 3. Why this sequential recording of these triplets is important is because if an event occurs in, let's say, the first trio here, you do not see how that is reflected in the other 9 leads. You'll see it in 1, 2, and 3, but you won't see it in any of these other leads. That's why it's generally important to put in a kind of scout tracing which shows you all of them. So let's look at some abnormalities, particularly of the heart, and vectorial analysis. And the first thing we're going to do is we're going to try to determine the mean electrical axis of the heart. This is, in fact, something that I think I have you do in lab anyway. So now, when we look at the current of the heart, current in the heart, it flows from an area, a depolarized area, to a polarized area. And the electrical potential, therefore, can be represented as a vector. And the arrowhead of the vector points in the positive direction. Again, if you go back to those lead placements that I showed you, those are your vectors. And we also, when we draw these, have the length of the vector be proportional to the voltage of the potential. So we set some standard, and then if we're measuring several different potentials, they're relative. And the potential can therefore be generated potential can therefore be represented at any given instant by an instantaneous mean vector. And when we look at the normal heart, the instantaneous mean vector, and this is determined by QRS complex, is positive 59 degrees. So notice these vectors again here. Here are the vectors showing you the direction of the current. So let's bring up this little thing because it's going to allow us to understand this idea of how we're going to determine that angle. So notice in lead 1, right arm negative, left arm positive. Lead 2, right arm negative, left leg positive. Lead 3, left arm negative, left leg positive. And in the augmented leads, we see in AVR, we have right arm positive, AVL, left arm positive, AVF, left leg positive. The axis of lead 1, remember the axis of lead 1 was horizontal. There it is, running across. So therefore, this is 0 degrees. It's on the line. The axis of lead 2 is plus 60. So if you take this as being your 180 to 0 line here, this angle from lead 1 to lead 2 is positive 60 degrees. And then lead 3 is another 60 degrees, or positive 120. So if you extend this out here, this angle that I'm drawing here is plus 120. And now we can put it all together in this circle of axes. You can see lead 1, here's the arrow pointing to 0. The arrow, remember the arrow head points to the positive terminal. In lead 2, plus 60, lead 3, plus 120. AVR is designated as being minus 150. So normally and canonically what we'll say is if you go this way, it's a positive angle. But if you go counterclockwise, then it's a negative angle. So we designate this as minus 150 rather than plus 240. Sorry, 210. This would be 240 up here. AVL, the axis for AVL going to the left arm is minus 30 degrees. And the axis for AVF is directly downwards, namely 90 degrees, positive 90. So when the vector has approximately the same direction as the axis of a bipolar limb lead, nearly the entire voltage will be recorded in that lead. So if you look at this idea here, here is negative to positive, and the voltage, the current, is going directly from A to B, which is in the same direction as the lead, so therefore we get this very strong positive deflection. If, on the other hand, the vector representing the mean direction direct current flow in the heart is perpendicular to one of the bipolar limb leads, the voltage recorded is very low. You could say it's zero, but sometimes it'll be a little off zero. So our current flow is from A to B, but our electrodes are placed here. So there is no current flowing toward an electrode. And if your vector has an opposite direction to the axis of the bipolar limb lead, then the entire voltage will be recorded in this lead. But notice that it will be a negative deflection rather than a positive deflection. So how do we use all this now to figure out the axis? This is the simple way, and is extremely useful when you only have 3 leads to deal with, if you're just using the 3 limb leads. Actually, in this case, you're going to use an augmented lead, but using the limb leads, it's the same thing. So what you do is you measure first the magnitude of the QRS in 2 leads. So in lead 2, we're measuring this as an arbitrary 2 units. And at AVR, we have an arbitrary 1 unit of magnitude, but notice that it's negative. So we take lead 2, we mark out on lead 2, which notice is the plus 60 arrow. It's a positive deflection. So we mark out a goodly distance there and call it 2 units and make a little tick mark. So there's our tick mark. And similarly, we then take our AVR lead, and we have 1 unit there. Notice our AVR is pointing up here to minus 150. If this were positive in AVR, then we'd be marking it over here. But it's not positive in AVR, it's negative in AVR. So that means it's going to be over here. So now we've got our 2 tick marks. The next thing to do is to drop a perpendicular from each of these lines at those tick points. So we drop a perpendicular from AVR, and we actually don't, well, we kind of do know where they're going to intersect, but imagining we don't know where they're going to intersect, you should make the line sufficiently long that you can get an intersection no matter which direction your other lead is going to be. And then similarly, you go to lead 2, drop perpendicular from it, and you notice these 2 perpendiculars intersect at this point. Oops, arrow disappeared right here. So now what we do is we go back and we connect the center of the circle with the intersection of the 2 perpendiculars. And this yellow arrow here now represents the mean electrical axis. And a close approximation would be to say it's 95, plus 95 degrees. Another way to do it is to find an isoelectric lead. Well, in this particular tracing, we have lead 2 and we have a lead which appears flatline here, no deflection on it, at least not for the QRS. And that would be our isoelectric lead, which is in this case AVL. So what we do is identify then the axis which is perpendicular to the isoelectric lead. All right, AVL is our isoelectric lead, and the lead which is perpendicular to that, notice AVL runs from 150 to minus 30. The lead which is perpendicular to that is going to be lead 2, which runs from minus 120 to 60. Now, how do we know whether we should therefore say our axis is plus 60 or our axis is minus 120. And the answer is we look at the lead that we chose, lead 2 in this case, okay? And we look where whether it's upright or inverted. So if the QRS on lead 2 is positive, then the axis is going to be plus 60 degrees. If it's negative, the axis is minus 120. You're probably very seldom going to see a minus 120. Now, the real problem with this method is that you quite frequently are not going to have a truly isoelectric lead. And so your estimation is going to be much less accurate than if you use the geometric method. The T wave, shown here in a standard EKG, is going to represent the ventricular repolarization. And repolarized areas are going to have a positive charge first. So therefore, you're going to get a positive net vector occurring in a positive T wave. Here we see the onset of any PQRS T EKG tracing, our first wave, which is the P wave. And you'll notice that the P wave is kind of, in the normal appearance, it's kind of rounded. And it generally should be positive in the 3 limb leads, leads 1, 2, and 3. This little box here shows you some variations in it, and also something else to point out, and that is when you look at the P wave in lead 2, in this case, you get a nice positive rounded deflection. Actually, most of the time you look at it, there's kind of a slight difference from side to side. But when you look at it in V1, what you see is that it looks biphasic, kind of like a sine wave. And the reason for that is simply the fact that you're seeing the effect of depolarizing the right atrium, followed by depolarization of the left atrium. And the depolarization of the left atrium, the current is running away from the V1 lead, whereas in the right atrium, it's running towards the V1 lead. Now, if you have a right atrial enlargement, not surprisingly, you're going to have an increased magnitude of voltage in your P wave, as you see here. And so you get this large increase and then a kind of a little plateau here. And then you go back to baseline. And in V1, this is demonstrated as a very sharp increase for a right atrial enlargement, and then this trough at the bottom of it. In a left atrial enlargement, you have your standard looking P wave, except it doesn't continue to go down. Now, since I've got more atrium in the left atrium, I get the second blip here. And also my P wave is kind of elongated. And in V1, this is shown as an elongation of the downward deflecting P wave from the left atrium. And if both are enlarged, you get this kind of fedora-looking appearance here, this being the little depression in the middle of the hat. So right atrial enlargement followed by left atrial enlargement. And then in V1, a combination of this tracing and this tracing. Atrial repolarization cannot be seen because it occurs during the time of the QRS complex. If you can actually see it, it gives a negative wave in leads 1, 2, and 3. Remember, our P wave was going to be positive in 1, 2, and 3, but the repolarization is going to be negative because it's running in the opposite direction from the current that we saw in the depolarization. Now, sometimes this is going to show up here in a normal EKG tracing as this depression here in the ST segment. So this is called a normal ST depression because of the atrial repolarization. And you can tell it's innate that because notice how this is going down. And if you keep following it, it looks just like that. On this example over here, it looks like our P wave is having that similar repolarization event, but it doesn't come out over here. Instead, we see that there's a much lower point in our ST segment. And this is an indication of some damage to the heart. So this is a true ST segment depression. Now, what can cause electrical axis deviation? Generally, what's going to cause axis deviation, other than a total repositioning of the heart, is going to be hypertrophy of portions of the heart. Now, the terminology that we go with is that all of this area from -30 to +120 is considered to be normal. Now, if we're in the range of 0 to +30, we don't say anything about it. We just say it's a normal axis. If it's in the range of 0 to -30, we say left axis, a left axis. 30 to 60, an intermediate, and 60 to 90, a vertical axis, and 90 to 120, a right axis. But it isn't until we get past 120 or past -30 that we introduce the word deviation. So greater than 120 is called a right axis deviation, and greater than -30 is called left axis deviation. So what can cause the axis deviation is first changes in the heart position. Dextrocardia, the heart's pointing to the right rather than the left. Pregnancy, the developing fetus will tend to impinge on the contents of the thorax by pressing against the diaphragm and may, in fact, push the apex of the heart out of a normal position. There is quite frequently a change in the heart during deep expiration, which is called an expiratory left shift. Lying down is going to affect it. And excessive abdominal fat, particularly peritoneal fat, will cause a change in the heart position. It's similar to the effect of being pregnant. And then we have the idea of hypertrophy causing a shift. And hypertrophy simply means an enlargement of the myocardium. And this can be caused by the hypertrophy of the left ventricle, can be caused by hypertension, because now the left ventricle has to work harder to pump the blood against the afterload. Or it can be caused by either aortic stenosis or regurgitation. And this is going to result in a prolonged QRS with a greater than normal voltage. In other words, greater than normal deflection. Hypertrophy of the right ventricle can also cause an axis deviation. And this can be caused by pulmonary hypertension, pulmonary valve stenosis, or an interventricular septal defect. Now, in the case of all three of these, what's happening is you're increasing the thickness of the myocardium in the right ventricle because it has to pump more strongly. In the stenotic thing, I'm trying to force the same amount of blood through a narrower opening. And the interventricular septal defect, since the left ventricle has a much higher pressure than the right ventricle, there's going to be more blood accumulating in the right ventricle than you would normally expect there to be. So again, it's going to have to pump out more blood. These all cause a slightly prolonged QRS and a higher voltage. A wide QRS, besides this hypertrophy that we've seen here, can also be caused by bundle branch blocks. In the diagram down here at the bottom, we see this concept of these two bundle branches. So here we have the SA node at 1, the AV node at 2, the bundle of His then dividing into a right and left bundle branch. And you notice they then now supply the myocardium. But if I have a right bundle branch block here, then the only impulse being conducted from the atrium to the ventricle is going to go down the left bundle branch. And that means that you're going to have to spread the current in the right ventricle through the myocardiocytes. So this gives you a prolonged QRS complex, rather than being the usual 120 milliseconds duration. QRS is now prolonged to a much greater extent. So for example, in this heart here, you can, this V6 lead here, you can see that I've got 1, 2, 3, 3.5 boxes there, which is taking me in the range of 130 to 140 milliseconds. Generally, in a right bundle branch block, the lead V1 will have a positive secondary R wave. So here is our positive R wave here, followed by QRS. And in V6, you notice how sloppy looking this S is at the bottom. It's called a slurred S wave. And here's a normal EKG, well, a 12 lead EKG showing a right bundle branch block. Now, remember I said that quite frequently you'll have this rhythm strip here, and also notice this little spike here, which is indicating 1 millivolt, so you know the scales are correct. But anyway, look at V1. So here is your RQRS complex that we saw. And when we look at V6, notice this slurred S wave at the bottom. A left bundle branch block will sometimes cause a left axis shift. Again, we have a prolonged QRS complex. So notice how spread out this is. And the characteristics of a left bundle branch block are lead 1 showing a very wide negative S wave, and V6 having this kind of rabbitier appearance to it. And here is a tracing of 12 lead of a left bundle branch block. And it's not as evident in that. First off, note V1, okay? So quite that deep S wave there. But notice in V6, that second little spike there, which is indicative of that rabbitier appearance that you see. Another thing which happens is increased voltages. If the sum of the voltages in leads 1, 2, and 3 is greater than 4 millivolts, we say that we have a high voltage EKG. And this is usually the result of a significantly increased ventricular muscle mass. How do we get this? The obvious is hypertension again, but it could also occur in a very conditioned heart in somebody like, say, a marathon runner. Now, notice we are asking, what is the sum of voltages in leads 1, 2, and 3? So we look at 1, and we see that 1's voltage is 1, 2, 3 boxes. So that's 1.5 volts. In lead 2, it's 1, 2, 3, 4 boxes. So we're now up to 3.5. And then in lead 3, we've got another 0.7 or so volts. So we're at 4.2 millivolts. So this is a high voltage EKG. And of course, notice how much voltage you see here in V4 and V5. In decreased voltages, this is a EKG tracing with decreased voltage. If the peak-to-peak QRS is less than 5 millimeters in the limb leads, and less than 10 millimeters in the precordial leads, then we have a decreased voltage. Look at these precordial leads. Minuscule voltage here. This is usually caused by abnormalities in the heart, such as a previous myocardial infarction, which results in a diminution in the amount of muscle that's there. The heart attack killed off a large amount of muscle, and now we have less muscle, so therefore less electrical activity. Now, there's some other things that can cause it: amyloid cardiomyopathy, pericardial effusion, pleural effusions, emphysema, and COPD. And of course, if your heart is reversed in position, then you're going to get a decrease as well, because you're now no longer running towards the electrodes. A prolonged QRS means that you've got an increase in the time that it takes for the electrical signal to move through the ventricles. And this is generally, again, due to hypertrophy of the heart. But it could be a Purkinje cell system block. Normal QRS is 60 to 80 milliseconds, up to 120 milliseconds. But if the QRS exceeds 120 milliseconds, it's probably due to a conduction block. And this tracing shows you these very prolonged QRSs here. One thing that shows up occasionally is when the myocardium is damaged, you may have a area of the heart which is totally depolarized all the time, or at least partially depolarized all the time. And what this allows for then is for the current to flow from these pathologically depolarized areas to your normal polarized areas. And so the causes of this current of injury, here we see this elevated ST segment here, can be a localized ischemia. It could be the result of infection, or even a result of mechanical trauma. And in this EKG here, I've pointed out with the green arrows 3 very prominent ST elevations in leads 2, 3, and AVF. Notice the ST in leads V1, V2, and V3 Rather than an elevation, you get an ST depression also in 4, and that kind of disappears when you, by the time you get to 5 and 6. I'm not going to spend too much time on this because it's sort of beyond what our knowledge is, but at least it points out something about how we can use these axes to, in fact, determine something about the way the heart is defective. So at the end of the S wave, when the ventricles are fully depolarized, this is called the J point. And what we do is we take the difference between the J point and the TP segment. And that difference, in other words, the voltage difference there between the J point and the TP segment, is the current of injury. And so you plot the voltages of the current of injury and the coordinates of 3 leads to determine the axis of it. And the negative end of the vector originates in the injured or ischemic area. So here you see how this is going to be applied. Here we have our QRS. Here's the S wave here. This is our isoelectric line here. Our isoelectric line is up here, the line which is our normal baseline. But our J point, notice, is down here. So this difference between these two, which in this example is 0.5 millivolts, is our current of injury. And now in this case, you'll notice that our baseline is here, because here's our P wave, and there's our J point at the end of S, and this is then going to be a negative deflection. Now you can determine then whether the current of injury is in the anterior or posterior wall of the heart by using the V leads. So if the current of injury in the chest lead is negative, the chest lead is in the area of negative potential. So that means that you have an anterior lesion. But if you have a positive current of injury in the chest lead, that indicates a posterior lesion. So in other words, the negative end of the current injury vector points to the abnormal cardiac muscle. So, and this isn't a chest lead, but again, you can see this application of being positive or negative. And this is showing you an anterior wall infarction. And here you have posterior wall infarction. Notice the direction. The next thing is to try to figure out what the nature of our myocardial infarction is. Now, in order to designate what we do to designate this is to call them either STEMIs or NSTEMIs. And STEMI means ST elevated myocardial infarction, and NSTEMI means non-ST elevated myocardial infarction. The ST segment is isoelectric, and it represents the interval between ventricular repolarization and depolarization, beginning at the J point. And it should be, the ST segment should be normally isoelectric to the TP and PR segments as well. In other words, along the straight line, which is the isoelectric line. Classically, you have a STEMI, an ST elevated myocardial infarction, if you have about 1 to 2 millimeters of ST elevation in 2 contiguous leads, or a new left bundle branch block. Now, we always, or at least classically, we call these ST elevations tombstones. or sometimes upwards in appearance. Tombstones was the common phrase, and it was actually in a way, a kind of dark humor, because an individual with a really significant ST elevation, tombstone, in fact, was going to end up with that. Now here we see the difference between STEMI and NSTEMI. Here's a normal EKG. This is our PR isoelectric line, our TP isoelectric line, and notice our ST segment is isoelectric with those. In the STEMI, on the other hand, here's our J point. Notice that we are elevated above the isoelectric line. So this is clearly a STEMI. On this EKG, you will notice that we have an ST depression, but not an elevation. So this is considered an NSTEMI, even though it has a clear-cut difference within the ST segment. And in this one, you'll notice that our ST segment is in fact isoelectric with both our PR and our TP intervals. But we, instead of having an upright T wave, we have an inverted T wave. And here you see an EKG tracing of a STEMI. And here is an NSTEMI. And you can see we have, instead of an elevation, we have a depression shown by the little blue arrows here in the various leads. If there's been a coronary thrombosis, in other words, clot forming within a coronary artery, and this gets resolved, the first thing that you will notice, the TP segment shows the current of injury following this coronary thrombosis. But interestingly, it tends to improve over several weeks, although exercise may in fact result in the appearance of a current of injury, at least for a period of time. And now we see this here. Notice we've got our ST depression here from our coronary thrombosis. And a week later, it's looking a little different. Here's our T wave here. By 3 weeks afterwards, our ST segment is isoelectric. And by a year later, everything looks quite normal, in fact. Now, when you have ventricular repolarization, it generally occurs in the opposite direction, depolarization. So your T wave in your leads 1, 2, and 3 should be upright. And if you get a prolonged T wave, this may result in a stranger looking T wave. Now, in this case, we have an example of a right ventricular hypertrophy with a widened QRS. You can see this. It's not immediately apparent, but the QRS is in fact widened here. And look at the T wave. T waves are inverted. So we have this inverted T wave abnormality. Digitalis toxicity. Remember, we use digitalis to, in fact, enhance our contractility of the heart because it blocks the sodium potassium ATPase and thereby results in the inability of the calcium sodium exchanger to work. And therefore, this is going to cause not only a prolonged contraction, but in toxic scenarios, is going to prolong the depolarization. and can cause a biphasic P wave. And you can see here's a biphasic P wave here, a couple of other biphasic P waves here and here. So now we can look at arrhythmias in the heart. And first, what we see here is a the indication of putting an electrode inside the heart. And I'm not going to spend a lot of time on this, but this is now what we're doing is recording intracardiac electrocardiograms. And there are different ways in which we can do it. And this first example here, you see we just have a tip electrode here. When we get our tracing, it depends on how the current is flowing. And on this, when we see pacemaker mechanism, we've got a tip, we've got a ring, and we've got a coil. And designations are tip to ring and ring to coil. And you'll see this a little later. And here you see how this all looks with intracardiac recordings here, and the standard EKG as well. But the little cine frame there shows you the pacemaker in the right ventricle. So we start with normal sinus rhythm. P wave QRST, heart rate of, well, in this individual, 1, 2, 3, 4 plus 4, 7, around 72 beats per minute. Now, in normal rhythm, normal sinus rhythm, well, first off, causes of cardiac arrhythmias. They could be the result of the pacemaker failing in some way. It could result from the pacemaker not being the SA node. It could be the result of blocks in transmission of the impulse, or abnormal pathways within the heart, or in fact, the generation of ectopic beats somewhere. Now, in the normal reading, we'd say that the P waves should look upright and similar. The PR intervals and QRS complexes have a normal duration, the PR interval of 0.12 to 0.2 seconds, and QRS 0.06 to 0.1 seconds. The rhythm is even and there are no unwanted patterns or lags in it. Our first condition will be sinus tachycardia. Tachycardia is a condition where the heart rate is higher than normal. So the impulses are going to speed up with the waves appearing more pronounced. It's important to note that if the heart rate gets too fast, what's going to happen is the overall efficiency of the cardiac cycle is going to decrease because you have insufficient time to fill the ventricles. There are various factors which can cause this condition. The heart rate tends to temporarily increase after extensive physical activities like exercise, and the heart rate tends to vary with age. Infants have an extremely high heart rate. It gradually gets slower with maturation and age. Possible conditions that can cause tachycardia, sinus tachycardia, are anemia, anxiety, fear, shock, changes in fluid volume, congestive heart failure, and some hypermetabolic states. Patients who take sympathomimetic medications are also prone to this condition. Now, it's certainly possible for people not to have any signs or symptoms when they have this condition. But some individuals may experience symptoms related to reduced cardiac output, like low blood pressure or syncope, syncope being fainting. They may also experience dizziness, obviously a rapid pulse rate, and shortness of breath. And a few may complain of heart palpitations. How do you detect the presence of sinus tachycardia in an EKG tracing? Well, here, if you look at this tracing, you'll find the P waves are normal. You have nice, normal little P waves here. There will be no abnormality in the QRS complex. So the QRSs look quite nice. The rhythm is regular, but the rate is fast. And so the waves look much closer together than each other. And the gaps between the QRS complexes are significantly less, showing basically that with the tachycardia, you're also reducing the QRS time. So in this particular heart, what is its rate? Well, again, taking our estimate, we've got this QRS on one big box and this one just before the second one, so 300, 150. It's a little over 150, probably about 152 or so. Sinus bradycardia is a slow heart rate. Now, this occurs because the impulse is released from the SA node slower than normal, which in turn causes the heart rate, obviously, to be less than 60 beats per minute. Bradycardia essentially indicates that there's some kind of problem associated with the SA node. If the heart rate is terribly slow, the heart may not succeed in pumping blood to all the different body organs, and this can lead to some very serious complications. Again, though, a slow heart rate does not necessarily mean a heart condition. Bradycardia is a common condition among athletes due to their increased vagal tone, and plus the fact that they have a much stronger contraction of the heart, and so can still maintain a proper cardiac output because their stroke volume output is increased. There are a lot of things that can cause sinus bradycardia: sleep, hypothermia, medications, increased intracranial pressure, and vagal stimulation caused by vomiting or suctioning, extreme emotions, severe pain. It can also occur be caused by disease conditions like hypothyroidism and myocardial infarction. Now, while people may not exhibit any sign or symptom of bradycardia, there are some, particularly those with pre-existing heart conditions, pre-existing health conditions, I should say, that do experience things like chest pain, fatigue, shortness of breath, syncope, and confusion. Some may complain of being tired easily during physical form of activity. So how do you determine a bradycardia in an EKG? Well, again, if you look at the P waves, you'll notice they're nice and normal and uniform and upright. PR interval is normal. The QRS complex is normal. Overall, the waves look normal. But when you try to calculate the rate, that's where you find the problem. So let's calculate the rate of this heart. So I'm going to take these two beats here. 1, 2, 3, 4, 5, 6, 7. 7 into 300 is 40, about 42, but it's actually more than that. So this is a heart rate somewhere in the vicinity of 40 beats per minute or less. That's an extremely bradycardic heart. Sinusarrhythmia pertains to a variation in the rate or rhythm of the heart. Rhythmia. In this case, the variation is due to a variation in the sinus, sinoatrial node. The rate of the heartbeat increases during inspiration, slows during expiration. While this does not make much hemodynamic effect and usually goes untreated, it can be caused, if there's no respiratory cause for it, by heart disease or valvular disease. You can also have conditions of sinus arrest, in which case you will generate no EKG at all. So now what we're going to do is we're going to look at sinoatrial nodal block, or SA nodal block. And SA block is a condition where the electrical impulse generated in the heart either gets delayed or totally blocked. This leads to delayed depolarization of the atria. It's different from delayed ventricular depolarization. It is caused by an AV block. Notice this is an SA block, nodal block. However, when the atria fail to be depolarized, the reason lies in the irregular functioning of the SA node. The causes for this condition are usually attributed to diseases like deterioration or malfunctioning of the SA node caused by endocarditis or coronary artery disease. It can also be caused by diseases like medications like digitoxin, beta blockers, calcium channel blockers. Again, the signs and symptoms of this condition are going to entirely depend on the severity of the block. Therefore, there'll be individuals who are totally asymptomatic, while others may have some symptoms related to reduced cardiac output like syncope and dizziness. Now, the way in which you tell that there is a sinoatrial block in an EKG tracing is you will find that there will be dropped beats. The dropped beats will occur after a cycle. After a dropped beat, the cycle tends to resume once more. Furthermore, you can also see that the block actually occurs in multiples of PP intervals. You're should expect a significant drop in the cardiac output because of this condition. P waves, PR intervals, and QRS complexes are normal, except for the rhythm, which can become irregular. And the rate can range from normal to slow. So as we look at this, which is a Mobitz type 1 sinoatrial nodal exit block, we see we have P waves, QRSs, inverted T waves in this case. Notice how this P wave isn't followed by anything. And then we see over here again, no P, we actually see no P wave here. So what's going to happen in this case, if you totally cease producing P waves, you'll establish a new pacemaker area within the heart, which will take over the role. In atrioventricular blocks, we have a condition which can be diagnosed by observing the EKG. Those who have an AV block will find that there's impairment in the conduction of impulses from the atria to the ventricles. Ideally, the SA node is responsible for setting the pace and regulating the speed of contraction. But in the case of AV blocks, the ventricles will fail to get this message from the SA node and the ventricles will come with their own pacing mechanism. And if they do so, then the heart rate gets slower because of this. Various causes for this, and here we see several of them. Ischemia of the AV node or the AV bundle, a compression of the AV bundle by scar tissue or calcified tissue, an inflammation of the AV node or AV bundle, excessive vagal stimulation, and again, digitalis, excessive digitalis. These are divided into several subcategories called the first, second, third degree AV blocks. The first degree AV block is a condition which is characterized by a notable PR interval prolongation for more than 200 milliseconds. In this condition, the impulse when traveling from the atria to the ventricles gets delayed because it travels slower than normal speed. Possible causes for this are enhanced vagal tone, again, especially true in athletes and runners. Diseases in the AV node, myocardial infarctions, myocarditis, medication or drugs, and electrolyte imbalances. The degree of AV block is still generally asymptomatic. This AV block is generally asymptomatic and can only be detected through an EKG. Usually this condition is not that serious and it's quite frequently just treated as being benign even when discovered. However, if it's accompanied with an acute condition of an acute MI, it can lead to some very serious atrioventricular defects. It can further aggravate the problem. So how do you detect a first degree AV block, the EKG? When you look at this, you will find the following characteristics. There is no change in the P waves. So P waves all look the same. However, the PR interval is longer, and the duration is longer than 200 milliseconds. QRS complex tends to be normal with a normal duration. So when you look at this, here's your QRS, T wave, and your P wave. Now, P waves, remember, are followed by QRS complexes. So where's your QRS complex? It's here. So notice the duration of this PR interval, okay, is 40 milliseconds. Two boxes. In a second degree AV block, this is similar to a first degree AV block. Again, an impairment in the conduction of the impulse from the atrium to the ventricle. And it occurs when more than one impulse fails to reach the ventricle. Cause second degree AV block is usually attributed to ailments and conditions that aggravate and damage the heart. Infections, metabolic disorders, heart diseases, structural heart defects, and even medication. The signs and symptoms, again, vary, since those experiencing type 1 will be more likely to be asymptomatic than those who have type 2 second degree AV block. Those with type 1 second degree AV block typically experience irregularities in heart rate, while those with type 2 experience not only the irregularities, but bradycardia and syncope as well. Now, we divide second degree heart block into two categories, one of which we call second degree type 1 block, Mobitz 1 or Venke block, And the second category is second degree type 2 block, or Mobitz 2. So here is the first category, the second degree AV block Mobitz type 1, or Venke block. Here you see that the PR interval gets progressively longer until you see that the P wave gets totally blocked and no QRS is produced. There's then a visible pause where the AV node recovers and the whole cycle starts all over again. So look down here at this tracing. Here we have a P wave which is not followed by a QRS. Here is the cycle starting. Normal looking P wave, fairly normal PR interval, perhaps a little longer than normal. And it looks a little longer here, a little longer, just a little longer here. And now it's gotten to the point where it's just a little bit too long. No QRS. This is go here, short, longer, 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 longest, etc. So it looks like we're dropping every fifth P wave. So we go 1, 2, 3, 4 with an elongation to the PR interval, and then the fifth P wave gets dropped. A second degree type 2 block, or Mobitz type 2, involves both the bundle branches. And so here, when you look at the EKG, you will find the distance between the P wave and the QRS gets wider with the conduction ratio that ranges from 2:1 to 3:1, or sometimes even 4:1. And people with this type of heart condition are generally going to be treated with artificial pacemakers to regulate their rate. So you can see this condition here. Third degree AV block, also known as complete heart block, is serious condition in which there is something causing the blockage of all impulses and preventing them from reaching the ventricles. As the impulse gets blocked completely, pacemakers in the ventricular chambers need to activate the ventricles so the impulse can be generated. What this appears in the EKG tracing is this. The rhythms are regular, but both the atria and the ventricles have independent rhythms. The P waves tend to be normal, but may get superimposed over the QRS complexes. There is no correlation between the P wave and the QRS. So in fact, one cannot really legitimately speak of a PR interval. So when we look at this, here's a P wave, P wave, P wave, P wave. P wave is somewhere here, kind of a biphasic looking P wave here. This P wave is probably buried in the T wave here. P wave, et cetera, et cetera. So there's a regularity in the P waves. And in fact, if we want to figure out what that regularity is, it's 1, 2, what is it? 1, 2.5, 150, probably about 120 beats. Whereas you'll notice that our QRS rate, 1, 2, 3, 4, so it's 75 and less than that. So our QRS rate is probably around 70 beats per minute. Stokes-Adams syndrome is a condition in which you have a complete AV block, like the tracing we saw the last one, but it sometimes is there and it sometimes isn't there. So in other words, it starts and stops kind of randomly, if you will. The ventricles stop contracting for about 5 to 30 seconds. The reason that they stop is because they're used to the atrial drive, and when the atrial drive fails to reach them, they sort of, if you will, don't know what to do. What the patient does in response to this pause in the heart beating is faint, because that's the brain's way of getting blood to it when the heart isn't doing its thing. Then you get a ventricular escape rhythm with an AV nodal or AV bundle rhythm. And these can be as slow as 15 beats per minute. In order to correct this, pacemaker is needed. And here you see an example of a Stokes-Adams syndrome tracing. Notice here's QRS, T wave, nothing, nothing, nothing. Q wave, QRS. A few more P waves before we get another QRS. This is not a happy way to live. In an incomplete intraventricular block, the impulse is blocked and sometimes not blocked in peripheral portions of the Purkinje system. And this gives you abnormal QRS waves. And again, your usual set of culprits, an ischemic event of myocarditis or digitalis toxicity. This is a fascinating type of EKG tracing. This is called electrical alternance. It's an incomplete intraventricular block. And I've actually seen this in a recorded EKG in a student. But since I'm not allowed to diagnose conditions, I simply said to her that she really probably should see a cardiologist to answer the question of what it represents. What electrical alternance is, it's an alternating QRS amplitude. So you say tall, short, tall, short, tall, short, and this is consistent in this EKG. In all the leads, or maybe only some of the leads of the EKG, with no additional changes to the conduction pathways of the heart. Typically, electrical alternance is associated with pericardial effusion via the swinging heart from the fluid surrounding the heart. In other words, the pericardial effusion, the fluid around the heart is going to make it look like it's in a slightly different position. So therefore, at one point you'll get a strong signal, another point you'll get a weaker signal. The heart axis is different. And you can very interestingly, by the way, calculate the axis of the heart for each of these beats and see that it, in fact, is doing this. Electrical alternance, however, is also associated with other pathologies, including, but certainly not limited to, ventricular tachycardia, Wolff-Parkinson-White syndrome, accelerated idioventricular rhythms, and supraventricular tachycardia. It may also occur in cardiac tamponade. I certainly don't think she had cardiac tamponade. Premature contractions are caused by ectopic foci. And this is usually the result of going to be a result of an ischemic event somewhere in the heart, which is going to cause this kind of almost irritation. Calcified plaques may cause it, toxic irritation of any of the conducting system, and this can happen as a result of drugs, nicotine, caffeine. Premature atrial contraction, medical condition that happens when the atria generate premature heartbeats. The premature heartbeats are seen as a complete EKG complex on the tracings. And we'll see this, you see this here. So we've got, if you look at the right-hand part of this strip, you see that it looks quite normal, but here we have beat, beat, and here is our premature atrial contraction here. Here's the P wave for that premature atrial contraction, and you notice the QRS follows then very rapidly from that. And there is then an increased delay until you get to the next normal P and QRS complex. This early contraction, of course, is going to be cause a decrease in the cardiac output because I've had much more limited time to fill the ventricle. These are usually caused by stress and stimulants like, again, coffee, nicotine, alcohol. They may also be caused by some underlying cardiac conditions like hypertension, valvular disorders, or previous MIs. And this is a regular EKG here of premature atrial contractions. It's not the best EKG for it, but certainly here and here you can see that it occurs. There also seems to be something funky going on here because you'll notice the variable profiles of the QRSs in this range here. Not quite sure what's going on there. But certainly in these first few beats here, everything is fairly normal. I suspect this individual has some underlying pathology. When we start getting arrhythmias that are not supraventricular anymore, but rather occur in either the AV node or the AV bundle, these are called junctional arrhythmias. And in this case, what you're seeing is two normal impulses. This is AVR here. P waves, normal upright P waves, nice morphology of your QRS. And that is then followed by this junctional P wave here. And notice we're now getting an inverted QRS complex. Now, also notice that your P wave here is inverted. And the reason that your P wave is inverted is because your impulse in the atria, since the signal is arising in the junction, is now progressing backwards away from your positive electrode. In this case, we have missing P wave. Missing P wave is actually here in this one. And if we have missing P wave in the tracing, this is generally another one over here. This is generally because it's in the mid-AV junction, which means that the missing P wave, in fact, is here, but it's obscured by your QRS complex. And if you have it way down low in the AV junction, then you get a late P wave, which is inverted. Now, these are normal. These first two beats are normal. This is now a junctional P wave. But notice the P wave is inverted because it's way down in the junction and it's going retrograde again. Premature ventricular contractions. We have generally in a premature ventricular contraction, we see a prolongation of the QRS complex. And the reason for this is that the impulse is conducted through muscle, which has, rather than through the conduction system. And that has a much slower conduction velocity than the conduction system does. The QRS voltage is also high because one side is depolarizing before the other. And you would expect to see an inverted T wave. Notice again the usual suspects here of cigarettes, coffee, and lack of sleep. Classic scenario for students. So here we see a PVC, a premature ventricular contraction in this EKG. Notice in leads 2 and 3, this appears inverted. Now, we don't know what this looks like in the other leads because we don't get one in the other leads. And remember, these are all sequential. So the only evidence of this PVC is in the 3 limb leads. And again, you can see that it's premature because it occurs much faster than your normal QRSs are here, and long before you can generate a P wave. Paroxysmal atrial tachycardia. Paroxysmal means a series of very rapid heartbeats that suddenly starts and then suddenly stops. This faked tracing here shows you a normal rate here, and then suddenly we get this tachycardic event occurring here. Now this is generally the result of some sort of re-entrant pathway, as I showed you in the cardiac physiology lecture. And the way to block interrupt one of these is via vagal reflex. And you can do this with a vagal carotid massage because your vagus nerve is right next to it. The use of beta blockers or digoxin. Paroxysmal ventricular tachycardia generally only occurs if there's been ischemic damage. And it turns out that you can block some of this condition with amiodarone. Here we see an interesting tracing of paroxysmal ventricular tachycardia. Notice that our individual is perfectly normal around here, this point here. Then we get a change in morphology and an increased rate here. So this is our tachycardia here. It's ventricular tachycardia. And then this is devolving here into a consistent VTach. Long QT syndrome can result in a congenital condition or an acquired condition. Congenitally, it is by mutations in the sodium-potassium channels. And the acquired condition is the result of either hypomagnesemia or hypokalemia. And this can lead to a very serious EKG, which is called the torsade de pointe. Now, to understand the torsade de pointe, you need to understand that you're getting a premature depolarization that is repetitive. So we see here is our normal electrical activity in a cardiomyocyte. And now all of a sudden what I'm getting is this premature depolarization occurring in probably our relative refractory period. And then that becomes repetitive. And so here we see, again, an imagined tracing here, where here's our normal-ish EKG. We have this pause, another QRS complex, a post-pause region, and then we have this event occurring here, irregular QRS complexes. Another pause and post-pause, and then we go into the torsade. And here is what torsade de pointe looks like in this case, this is a 12th lead, and your rhythm strip at the bottom is lead 2. You actually get to see what it looks like in the different leads compared to what we're seeing in lead 2 there. Ventricular flutter is a condition in which you have these broad flutter waves. Now notice the rate here is, let's see, it's slightly greater than 300 beats per minute. This is a very poor condition to have because it basically means you're not going to be able to effectively pump blood. Ventricular fibrillation, in flutter, there was kind of a coordination to the beat, just very rapid kind of beat with not much time to fill, so therefore not much delivery of blood. But in fibrillation, you have a totally uncoordinated series of contractions. They just quiver effectively, which means that the efficiency of the heart to pump is nil. The causes for ventricular fibrillation are the same as for ventricular tachycardia. In fact, most of the time, ventricular fibrillation is preceded by a ventricular tachycardic event. Now, other causes for ventricular fibrillation can be a electrical shock or coronary artery disease. Now, these are effectively, ventricular fibrillation is effectively a circus movement, meaning we may have a long pathway. For example, in a dilated heart, you have a long pathway. Or you could have a decrease in the conduction velocity, which would give you a long pathway as well, which can be caused by Purkinje system blockage, ischemia, hyperkalemia. And if the refractory period is shortened, then the cause is probably epinephrine. Now, in this idea of the way ventricular fibrillation ends up, in our normal pathway, you'll notice that we send this signal around, and by the time the signal reaches the start point, we're still in absolute refractory period. So that means we cannot generate another signal. But if we elongate that pathway, either by slowing the conduction or dilating the heart, then you'll notice we get back to the start point when we're now either relatively refractory or not refractory at all. And this is a tracing of ventricular fibrillation. Actually, this began over here. These 3 beats here are actually a ventricular tachycardia. We're kind of tachycardic even between these 2 beats, because you'll notice we're 300, 150, we're about a ventricular rate of about 120. But then that shortens to, in these last beats here, to 300, and now we go into the fibrillation. To get out of ventricular fibrillation, your best bet is to defibrillate, in which case you're going to apply a high voltage current for a few thousandths of a second. And this makes the entirety of the heart refractory. And the heart then remains quiet for about 3 to 5 seconds. And a new pacemaker hopefully is established. To be effective, defibrillation should occur very quickly after a witnessed event. Ideally, less than a minute, but even up to about 5 minutes is probably going to do some benefit. Beyond that period of time, you need other means of trying to manipulate the heart. Atrial fibrillation is an uncoordinated set of contractions within the atria, much like ventricular fibrillation, but generally occurs without ventricular fibrillation. And again, it's going to be due to an increased distance that the conduction has to go through. In other words, a circus movement there. And this is going to decrease your effectiveness of ventricular pumping, because you're no longer going to have the squeeze, which is going to propel the blood. And this tracing shows you an atrial fibrillation. So these very little sawtoothy-like lines here, actually more like file lines, are the fibrillation. Flutter, on the other hand, is a kind of signal that it's sort of like the wave at a ballpark, if you will. A single large impulse wave that travels around the part. And it may have rates of anywhere from 200 to sometimes as high as 400 beats per minute. But the AV node, if the AV node is still functioning as the way it should, will not pass the signal to the ventricles until 350 milliseconds have elapsed from the previous signal. So therefore, the atria can contract multiple times more rapidly than the ventricle will, because we have a variant conductance. And in this tracing of atrial flutter, the two red arrows indicate you have two types of AV conduction. The arrow on the left shows you a 2-to-1 conduction, whereas the arrow on the right shows you a 4-to-1 conduction. Now this looks like an atrial fibrillation, but it isn't. This is a normal sinus rhythm with what it says, a baseline artifact. And the baseline artifact in this case is the fact that the patient is a Parkinsonian and has an underlying tremor, and it's that underlying tremor which is causing the baseline artifact. Cardiac arrest, in other words, the total stoppage of contraction in the heart, is due to extremely hypoxic conditions in the heart, which effectively, if you will, stops the sodium-potassium pump because the mitochondria run out of oxygen and therefore can no longer make any ATP, and therefore this gets depleted. And there, in cardiac arrest, there are the 5 H's, 5 T's that one should follow. So notice that you should look for hypovolemia, hypoxia, acidosis, i.e. hydrogen ions, hyperkalemia, and hypothermia. And you should also, in the 5 T's, look for toxins, tamponade, cardiac tamponade, tension pneumothorax, myocardial infarction, thrombosis, or pulmonary thrombosis. And in this artificial trace, you see a ventricular fibrillation converting to flatline asystole. There is absolutely no cardiac activity in asystole. So with zero cardiac activity, you get no impulse generated, and therefore neither the atria nor the ventricles are going to contract, so you have no blood flow. And you can classify asystole as being primary or secondary. Primary happens when the heart's conduction system intrinsically fails to generate ventricular depolarization, probably as the result of either degeneration in the heart tissue itself or ischemia of the SA or AV node, occlusion of the right coronary artery or extensive infarct. Secondary asystole happens when extrinsic factors cause a malfunction in the heart's electrical conduction system. Possible causes for this include near drowning, stroke, suffocation, and complications of myocardial infarction. In asystole, one should perform CPR the earliest possible time to hope to rescue the person, because otherwise the individual is going to have death. Sometimes electrical shock needs to be administered, although it generally is not that effective. Now, how do you detect asystole? Well, you have this flat line here. Now, by the way, I'm going to point out one other thing in this. If this were a normal rhythm, rather than the ventricular fibrillation that we see here, and this led up then to an asystolic event like this, and your little monitor went off, should you immediately start compressions in the heart of this individual? And the answer is, why don't you assess the patient? If the patient is very happily lying there, talking to someone, the patient is not an asystole. What you have instead is a failure of the recording equipment. So the mantra that goes with this is treat the patient, not the machine. And here we see an example of cardiac arrest where we have a ventricular asystole, but we still have atrial P waves. This is a condition called pulseless electrical activity. We used to call it electromechanical dissociation. And here the heart fails to produce a pulse, hence pulseless electrical activity. There is electrical activation, an impulse is generated, but the muscles don't contract. So what are the causes for this? They could be pulmonary embolism, tension pneumothorax, hypokalemia, myocardial infarction, acidosis. In other words, there's this whole litany of things which might cause this condition, including some drugs like beta blockers and cyclic antidepressants. So in pulseless electrical activity, there's the absence of heart tones upon auscultation. In other words, you don't hear lub-dub. There's apnea and a lack of pulse. Now, if you take a look at the EKG tracing, you would note that despite the presence of an electrical activity, everything from the rate, the rhythm, the P waves, the PR interval, QRS complex reflect only the underlying rhythm. In other words, you can't tell looking at this EKG that you in fact have pulseless electrical activity. So if you have another monitor like a pressure monitor and it tells you there is nothing going on, that's what you should pay attention to. And now in this tracing, we see an intracardiac electrodes here. So we've got an EKG from tip to ring and an EKG from coil to can here. We have a sinus rhythm which devolves into a polymorphic, meaning multiple different forms, tachycardia, continued rapid polymorphic ventricular tachycardia, devolves into a ventricular fibrillation, at which point the intracardiac defibrillator administered 36 joules intracardiac shock. And you notice that put everybody into absolute refractory period. And then we restored a rhythm. It's not a great looking rhythm, but it's a pretty good rhythm. And this slide is another interesting case. In this individual, and you can see this particularly in the V leads, see these spikes here. These are pacemaker spikes, particularly they're ventricular pacemaker spikes. And what you see is that in order to generate the ventricular QRS complexes, we need to administer this shock to the ventricles at that point. Now, for some reason unknown, it fails. And so once it looks like it's still administering some current to the patient, but notice there is no QRS complex. So this individual is pacemaker dependent, and as soon as the pacemaker isn't delivering the proper voltage or whatever, the individual goes into asystole. And now for my last slide to conclude the lecture, I mentioned Willem Einthoven earlier, and this is a portrait of Einthoven's lab. And you can see his various assistants around here. This is Einthoven, sorry, elegant looking individual. Here is Einthoven, and I do not understand this guy. He looks quite strange. But after all, this is around the turn of the 19th, 20th century. But look at all the lab equipment over here. He's using very primitive electrical circuits and all the rest of it. So that concludes my lecture then on electrocardiography. And I point out to you that you have the first of the intraterm exams. You have about a little more than a week to complete it. And next week I'll start on immunology, and that'll take me a couple of weeks to go through. So until then, I wish you all a good evening and a happy weekend, and stay well.
Thank you.
Thank you, Professor.